bear with me. So those are the first three things we need to think about. We need to identify what the actual issues are, understand that it's key that we see both male and female if at all possible, and thirdly, it's about using an integrative approach. So it's understanding what tests are useful, when to use them, how to use them, and how to interpret them. So they're really important things, and we aim to cover that in the course. So 1 in 6 couples in the UK now have difficulties conceiving, and actually that is reflected globally. Statistically, they are the couples that present for medical treatment, but what we know is that there are many others who are having difficulties but just don't present for treatment, and sadly they suffer in silence. They can't bear the thought of going through a barrage of tests, etc., and so we don't get to hear about them. So important to remember the contributing factors, as I've said already, a third male, a third female, and a third joint. And what that means is that males are involved in 50 to 60% of all cases of not just difficulties in conceiving, but in also in repeat miscarriage. So, we have a lot of women who have very early miscarriage, they have failed IVF cycles, and it is as likely to be male factor as it is female factor, and we like to look at those issues and work with them to improve outcomes. And that's very much where we refer back into medical care for testing. The other thing to be aware of is that male fertility declined and is continuing to decline. Over a 25-year period, it declined by 50%. So in the 1950s, one example I like to give, currently what we have is when they are testing semen samples, a good or borderline sample would expect the morphology of the sperm, so that is how the sperm are formed, to be greater than 4%. Now that means that 96% of the sperm can be abnormally formed, and that would be classed as a borderline normal sample. That means that 96% of the sperm are absolutely of no use whatsoever. Now in the 1950s, you would expect 80% of the sperm to be normally formed. So from the 1950s to 2019, we've dropped, from 80% down to 4%. It's a huge, huge decline. What they're saying is that if this decline continues, by 2050, the human race will be in real difficulties. And we need to do something about that. And it's a complex picture, it's not any one.
Yeah.
So we really need to engage with men. It's very important. And one of the reasons it's very important for us to do this is that the fertility clinics very often overlook the male factor. They have they're kind of looking from the other end of the telescope. So they're looking to see under their microscope, have we got some sperm and can we use them in a cycle of IVF, or are we going to have to use ICSI, which is fertilization? And actually what they don't look at is the functionality of those sperm and what's contained in the head of the sperm too, which is where the DNA and the chromosomes are. So unless we get this right, we can have cycle after cycle of IVF and it will fail because no one's looked in detail at what's happening for men. So I think a lot of the work we do isn't just about reflexology, it's about signposting on to make sure that clients get the best possible fertility journey for them, and they make sure that they get the appropriate tests that they need. Okay, so really important. Okay, so what makes reproflexology different? So it aims to identify causes before treatment, and that means forming collaborations with fertility clinics and other medical test providers. We don't see it as either or, we see it as a collaboration, as an integrative approach that puts the patient at the centre. So it's a patient-centred approach to make sure they get everything they need to be as successful as they possibly can in as short a time as possible. And that's really important. So we use this integrative approach, which includes medical tests, and also what we have is something called the Repro assessment. That's our diagnostic tool, and it's one of the first pieces of practical that I teach you and when we do the course. So that allows us to have a look at the feet, the colour of the feet, the temperature, and feel the reproductive reflex points in detail to make sure that systemically the clients are well, because that impacts upon their fertility health, and also to make sure that the right things are happening at the right time in the menstrual cycle, and also that there are no anomalies that we should be aware of. So often when you identify something, you'll ask your client about symptoms and they will match what you think that you are able to feel in the feet, and you can send them back to caregivers to get that properly. Sorry, my screen keeps dropping out here, so I should keep sharing. So it aims to treat a wide range of conditions that impact health, including regulating menstrual cycles and ensuring that each stage of the menstrual cycle is functioning at its best. Now, it's absolutely fascinating because I would say 95% of women who present for treatment think they know how their menstrual cycle functions and actually have no idea. And there is this medical norm, which is the fact that they think it should be 28 days, when in actual fact, every woman is different. It's the regularity which is what's important, actually making sure that the cycle is stable and all the varying component parts are doing what they should be doing. And we cover that in detail in the course. It's really important. And sometimes it is as simple as having maybe the luteal phase, so the second half of the cycle, not functioning as it should be. And we regulate that, and it means that they can fall pregnant and sustain a pregnancy. We also want to improve sperm production and functionality, so the numbers of sperm, how well they're swimming, and how well they're formed. And there are lots of different ways of doing that. So, we use reflexology techniques, and we also recommend sort of diet, nutrition, and lifestyle recommendations to help clients, to empower them really, so they feel they're doing something as well that will help to improve their fertility. We use very structured, restrictive treatment protocols for many women. Now, what's fascinating about these is they are measurable and they're evidence-based. So they were developed over many years by, right early in my practice, realizing that what I could feel in the reflex points was then being confirmed by an ultrasound scan or a blood test result or a semen analysis. So to give you an example, you may find that, say, the ovary reflex point, you feel what feels like a very large cyst sitting there, and then you'll have a client who goes to have an ultrasound scan and they confirm that she does in fact have a cyst and it's on the left ovary reflex point, which is exactly where you feel it. Wow. And then you may have a male who's not producing very many sperm, as there's very little activity in the testes reflex point because there's low testosterone levels, low blood flow, and therefore he'll go and have a semen analysis, and that reflects what you can feel in the reflex points. So the techniques are designed to either mimic what should be happening naturally or overcome an issue and actually encourage the body to achieve what should actually be happening. So they have an evidence base behind them. And they are measurable because, so one of the examples I like to give is you may have a male that comes to see you and he's got a very poor semen analysis, he's had an intake semen analysis, and we work with him for 12 weeks and then he'll have a repeat test and you can see all the parameters have improved. So you're actually using science to measure the effectiveness of reflexology, which is quite incredible actually, it's quite exciting. We also work to support all forms of assisted conception. Now, this is quite fascinating because what we're doing here is turning reflexology on its head. How we always normally use it is to support what's happening naturally within the body. But actually, when your clients are taking very potent drugs, we want to support what those drugs are trying to achieve. And if we try and get the body to do what it should be doing naturally, we're going to be working against what those drugs are setting out to achieve. So what we do is understand what the drugs are trying to achieve at each stage, for example, during the cycle of IVF, and then we mimic what should be happening from an endocrine and reproductive point of view in response to taking those drugs. So it's that understanding what the drugs are doing and then using reflexology to support that. So again, that's quite fascinating. And it means you work very closely and very dynamically with them. So I like to give an example, and actually this is a client of mine who very happily has shared her charts with us, which makes it a very visual example of how this works as a form of treatment. So one of the things which is very common is that women can have in their menstrual cycle a short luteal phase or progesterone deficiency. And that means that the period of time from ovulation until when they start their next period is either too short, so it's less than 10 days, or they're not producing enough progesterone for long enough. So they get a little spike in temperature, which I'll show you in a moment, but it doesn't stay up for long enough. And that means it's very difficult to actually have enough time for implantation to take place. But it also means that it's almost impossible to maintain a pregnancy with that picture. So what we might have is poor progesterone blood chemistry. So they may have had a blood test taken 7 days post-ovulation, and that's not showing very good results. Or they may, as well as this, have spotting leading up to their bleed. And that spotting leading up to their bleed is a real indicator that the endometrium is starting to break down too soon, and we really don't want to see that. So we use basal body temperature charts, and I'll explain those in just a moment because that gives us a much better picture of what's going on. So it's very visual. Does anyone use these? Or have used them?
No, I'm not there yet.
Okay.
No, but this is probably one of the most interesting things that I'm looking forward to learning is taking something like this and implementing it from a consultation standpoint.
Okay. It is absolutely fascinating. I use these every single day in my practice, and I have clients sending them to me. So I'll give you a little resume of what's happening here. This belonged to a client of mine who said, I have a 28-day cycle. I really don't want to chart. There's nothing wrong with my cycle. It has always been 28 days, and I don't think there's anything wrong with it. So I persuaded her very gently that please could you do it just so that I would have some information to confirm, what was happening in her cycle. So I'm going to do some little drawings in here. So just my pen. So one of the things to say is that each of these little dots is a temperature that your client has taken, and she must take her basal body temperature. So that is the body's temperature at its lowest level. So when we go to sleep at night, our temperature drops down to its basal level, its lowest level, after 3 hours of sleep. And if we take the temperature as soon as we wake up in the morning before we do anything, so eating, sleeping, drinking, anything at all, it gives us a very accurate reading, because what we are measuring here is not even a whole degree change in temperature. We're measuring points of a degree. Okay. So your client takes the temperature first thing in the morning before anything else happens, and it allows us to have some kind of accurate reading as to what their temperature is at that point. Now, what we know is that either just before the bleed or during the bleed, the temperature drops down, okay? And it then fluctuates around a little bit. And then at ovulation, that temperature has a marked rise. So we can see that ovulation has taken place here. And the reason we see that rise is because during the cycle, the menstrual cycle, in the follicular phase, which is the period of time from bleed until when ovulation occurs, follicles are developing in the ovaries, and inside the follicle is a little tiny egg. And that egg, as it becomes more mature, starts to secrete estrogen. And estrogen is responsible for lots of things, but in the main, thickening up the endometrium. When ovulation occurs, that follicle ruptures and it releases the egg, and immediately what forms in that ruptured follicle is what's called the corpus luteum. It's a yellow mass that is in that follicle, and it starts to secrete progesterone. And as it does that, it elevates the basal body temperature, and the temperature should then maintain itself at a high level until the next bleed starts. You can see it happening. Fascinating, isn't it? Absolutely fascinating. So, what we can see with this chart, first thing is that she actually, although the algorithms of the chart based on her information has put ovulation on day 17, actually not until day 20 of her cycle. Okay, because that's when you can see not only the steep rise, but the rise above the baseline. They've put the baseline much lower, and I would say that the baseline is probably along here somewhere. Here we can see this lovely rise. So in addition to that, what you can see is these temperatures are fluctuating wildly, and we only have 1, 2, 3, 4, 5, 6, 7, 8 days before her bleed starts. Okay, here is day 1. So from here to here, we have 8 days, which is too short. It needs to be at least 10 days. Okay, so already this was a woman who thought there was nothing wrong with her cycle. We can see that her luteal phase is too short. Yeah. In addition to that, these little asterisks indicate spotting, and she has 5 days of spotting leading up to her bleed. And that again tells us that we have a progesterone issue. The endometrium is starting to break down too soon. That means there'll be no window of opportunity for implantation to take place. And it also means that that she wouldn't sustain a pregnancy with that picture. In addition to that, so you can see along here it says CM, which stands for cervical mucus. So she can note on here changes in cervical mucus. Now, we've got some sporadic changes which really aren't telling us very much. We've got 1 day of egg white cervical mucus, but it's up on the wrong day. It needs to be really in the lead up to and including ovulation. So that means if she's not producing the right kind of egg white cervical mucus around ovulation, then she's unlikely to get pregnant, because most of the time cervical mucus is hostile to sperm. It's too acidic. Sperm like an alkaline environment. So this lady, this already tells us exactly why she is not getting pregnant. So the wrong kind of cervical mucus, she's got spotting leading up to her bleed, insufficient progesterone, and her luteal phase is too short. And so that was quite astounding for her to realise that all of these things were going on without her realising. Okay, so what did we do? This is where it becomes really fascinating. So what we did was we treated her weekly throughout her cycle using protocols that supported each stage of the menstrual cycle. Okay, to mimic what actually should be happening, to remind the body that during the bleed, everything's quiet, we need to clear out the endometrium. From end of bleed up to ovulation, there's lots of activity. We need to see the endocrine system working really efficiently, and as a result of that, the reproductive system. So we have protocols that are designed to do that. And then from ovulation to bleed, what we needed to do was stimulate the ovary reflex point to encourage that corpus luteum to produce more progesterone. And in addition to that, we got our clients to self-stimulate their ovary reflex points. With this lady, it was 5 times 90 seconds a day. So showed her how to work the ovary reflex point on her hands and how to stimulate in the right direction. And we got her doing that 5 times 90 seconds a day to support the production of progesterone by the corpus luteum. And then we had ongoing monitoring. So what happened was the spotting stopped, the PMS that she had stopped. She also had cyclical headaches, which she got as soon as she started producing progesterone. So that disappeared. We saw changes in her basal body temperature charts, and I'll show you those in a minute. And her repeat progesterone test at 7 days post-ovulation at the right time was improved. So this was the improved chart. So we worked with her through 2 cycles. So the first thing to say here is that, let me just get my pen, that we didn't change the length of her cycle. She still had a 28-day cycle. So without monitoring, she wouldn't have known that these things had changed. You can see that we brought ovulation forward to day 12. Here's that lovely steep rise. In the 5 days up to and including ovulation, she produced 5 days of lovely egg white cervical mucus. That's absolutely key. Her luteal phase extended to 16 days, which was absolutely perfect. And we got rid of all the spotting beforehand. Okay. So this is fascinating because you're actually seeing reflexology in action, and you can evidence base it. You've got a before and an after, or you've got a continual process as clients are going through it. You can see the changes taking place. And as I say, I read these all of the time. I get clients sending them to me. The charts that we use are called fertilityfriend.com, Kerry. It's a free to use service, and clients can just go and sign up to it. And I usually recommend that you sign up yourself. Might be difficult for you, Sam, but I would say go and sign up yourself, and it sends you a series of little emails, and it's a really good way of actually getting an idea of what you're going to be recommending your clients do. But this is a fantastic resource, and certainly an amazing means of identifying where the issues are, and then using the charting to actually see what effect the reflexology is having. So, okay. We also look at the reflex points in much greater detail. So these are just some simple drawings, but what you will see in the ovary reflex point is that we actually look at the development of the follicle in the ovary as it gets bigger, right through to the corpus luteum and the corpus albicans, and how that cycle of events takes place in the ovary reflex point. And the same applies in the uterus. What we are feeling for are the changes that take place throughout the menstrual cycle in the uterus reflex point. Okay, so that makes it, we're really just getting you to feel in minute detail the differences that take place. We also work on the direct reflex point, or on the sole of the foot as well. Okay, and we also teach clients how to work their own reflex points either in the ears or on the hands. Okay, so that we've really developed the hands along with the lovely Lynn Booth, who helped us to transfer our techniques onto hand reflex points, so that we can work on those and make it easier for clients to do their homework, because actually getting clients working on their feet is really tricky. So working on hands is much easier. So let's talk a little bit about men. One of the most common things you'll see is the functionality of sperm. So quality, quantity, and underlying conditions that impact upon the quality and the quantity. So some of the things we look at are things like hydroceles, varicoceles, epididymitis. So hydroceles are fluid around the testes. So if you're kind of looking at I don't know whether you can see this, but if you're looking at the testes reflex point, what tends to happen with a hydrocele is that it gets quite waterlogged behind. It becomes quite puffy and it pits. And a hydrocele can develop as a result of a trauma, or as a result of an infection, or sadly as a result of something more sinister. So clients do have that. They really do need to go and get it checked out. And the same with a varicocele. Varicocele is like a varicose vein in the testes. These things have an impact upon sperm, and they cause damage as they are developing. Now, once sperm have developed, they move up to the epididymis, which actually basically kind of sits on the top of the testes, and it's where the sperm are stored. So if you have someone with an inflammation, epididymitis, and inflammation of the epididymis, then what happens is when they're being stored, they get damaged. So we need to make sure that clients go and get those things checked out properly. They have proper medical intervention, and then we have some techniques that we use that improve outcomes for that. So usually what we like is an initial semen analysis. So it's very easy for men to go and get a baseline semen analysis undertaken, and that provides us with some basic information, which we'll talk about in a moment. We also need to work upon reduction of stress, because we know that stress in particular causes high levels of free radicals and oxidative stress, which damages the DNA in the head of the sperm. And if that sperm DNA is damaged, that will cause repeat miscarriage and inability to conceive, because the information that is contained in the head of the sperm is being passed on to the embryo. And if it's faulty in any way, then you're going to end up with faulty embryos. So it's really important that that's dealt with. And we want to make sure that both reproductive and endocrine systems are functioning as they should, because if they're not, then they're going to have a knock-on effect on how the sperm function themselves. So one of the things that we look at, the most important thing that we look at to start with, is a basic semen analysis. And these are the current World Health Organization semen parameters. And what they look at is the volume, so the amount of seminal fluid that's being produced, the pH, because we know sperm like an alkaline environment, the sperm concentration, so how many sperm there are per milliliter of fluid that is being produced, the total count, so how many there are, these are all in millions, we'll talk about the parameters in a minute, the percentage that are moving, and the percentage that are moving progressively. So what that means is they need to be moving forward in a linear direction, so that some of them are moving slowly, some of them are moving fast, but we need to have a good percentage of sperm that are moving, because it's no good if they're going around in circles or hovering on the spot or going backwards. They won't get to where they need to be. And then the morphology, which we've already briefly talked about, this is quoted as a percentage, so it needs to be above 4% of the sperm are normally formed. So they need to produce at least 1.5 milliliters of seminal fluid. The pH actually should be between 7.2 and 8. They need to have a minimum of 15 million sperm per milliliter, and a total count of 39 million sperm as a minimum number. 40% need to be moving, and 32% need to be moving progressively. So they are World Health Organization basic reference ranges. We like them to be higher than that. And actually, although 39 million sperm sounds like an awful lot, when we're teaching, we actually go through the stats for you, and you can see that actually that's a very low number, because it's an arduous journey for sperm to get to where they need to be. And our aim is to make sure that our males achieve this as a minimum. Okay. So really important. So semen analysis. We then have an 8-week program that is designed to improve any underlying condition and also to improve quality and quantity of sperm. Now, the reason it's 8 weeks is because it takes at least 8 to 12 weeks for sperm to develop and be ready for use. And we look at how they develop during the course. We actually look at what the development process is, how they develop, and how important that is in terms of being effective. And so the minimum we do is eight treatments on a weekly basis to support the endocrine and reproductive system. And then usually we like to do a little repeat test at that stage to see how things are improving. Okay, and here we've got, again, our male reproductive reflex points. So we've got the testes with the seminiferous tubules, and actually dotted in there are Leydig cells, which are responsible for producing testosterone. We also look at and feel the prostate in quite a minute detail, because up to 90% of the seminal fluid is produced in the prostate. If the prostate is inflamed or diseased, has an infection of some kind, that's going to impact upon the quality of the seminal fluid and in turn will damage sperm. So we really need to have good, well-functioning prostate. So that's just another view. So initial consultation, really important. We start with the course with looking at gathering the most relevant and thorough information relative to fertility and reproductive conditions. And the initial consultation process for us is consultation only, hopefully coupled together, followed by the repro assessment. When they come to see us, what we do first of all is we send out a questionnaire. So it kind of primes them for the things you're going to be discussing with them. And it also means that they can then bring that along. They can complete it at home, bring it with them. And we ask them to bring with them also copies of any relevant test results. So it could be things like FSH and LH, so follicle stimulating hormone, luteinizing hormone, prolactin, estradiol, progesterone, and a semen analysis. If they have those things, we like them to bring them with them so that we can see the whole picture. And we teach you how to interpret those on the course, so you understand the relevance of them and what might need to happen as a result of the results not being quite as they should be. So it allows us to form a whole picture. So first appointment, consultation only, usually takes about an hour and a half to go through all of the information. We look at their fertility history, their gynae history, general medical history, and then we flesh out what is in the preconceptual questionnaire, and we provide you with a copy of this on the course. So also for women, we need to know lots of information about their menstrual cycle. So the length of their cycle, the length of their bleed, what ovulation signs they have, if they have any. So some women get a mid-cycle spotting, or they get a bit of one-sided pain, or they're very aware of the changes in cervical mucus, so we ask them to identify those. Whether they're getting any PMS symptoms, because we shouldn't get them, and if we do get them, they should be mild, so we like to discuss those. Whether they're getting spotting prior to their bleed, and what their bleed is actually like, so that its colour and the level of clotting, if any, because what it should be is nice and fresh. What we don't want to see is dark bleed, lots of clotting. That's a sign of debris and stagnation, and we would want to improve that. Okay. We also gather relevant information about nutrition, diet, lifestyle, and we carry out this repro assessment, as I say, which is the first thing that we teach you on the course. It's quite fascinating. And then once we've collated all of the information, we plan treatment with them so they know exactly what is going to happen. So if you've got a woman whose cycle isn't functioning very well, you're going to want to treat her weekly throughout her menstrual cycle. If you've got a male who is, has got a poor semen analysis, he's going to understand that he's going to need 8 weeks worth of treatment before we start doing any further relevant testing. So it's a really good way of planning treatment with clients. and you're able then to actually refer them on for relevant testing if needed at that time. So how effective is it? So as an organisation, the Association of Reproductive Reflexologists, we carried out a data collection on 180 clients using these very structured protocols. So they were age range 24 to 46. They had an average of 11.5 treatments, and we had 122 pregnancies, 100 naturally and 22 alongside IVF and ICSI. So we had 122 patients conceived, 100 naturally, 22 with IVF and ICSI, and a success rate of 68%. So that took us by surprise. We weren't really expecting that. Success rates for IVF are across the board. If you put everybody in the same pool, they're about 25%. So this was hugely different. When we look, actually just last year, I extracted this data just looking at the IVF, and we increased the success rate from 25% to 52%, which is a huge difference. That's doubling success rates with using reflexology and IVF ICSI. And then we looked at varying conditions. So we looked at unexplained infertility, those who had endometriosis, those who had PCOS, amenorrhea, so no bleeds at all, progesterone deficiency, and ovarian cysts. And what we did was we looked at the pregnancy rate and the live birth rate. Now, I'll show you the data in just a moment, but what you'll see is that with some conditions, there is a lower live birth rate because, particularly with things like PCOS, because of fluctuating hormones, that has an outcome on sustaining a pregnancy. So you tend to get a higher miscarriage rate. But the data was, so unexplained, we had a 70% pregnancy rate and a 70% live birth rate. With endometriosis, it was 65% and 55%. With PCOS, a 72% pregnancy rate, 57% live birth rate. Amenorrhea, much higher, 91% pregnancy rate and 70% live birth rate. Ovarian cysts, very successful. Once they'd been remedied, then there wasn't an ongoing issue. And I think that's because with ovarian cysts, sometimes if they're functional, which means that they interfere with how the reproductive system works, then if you can remove that, then that removes the ongoing effect on pregnancy and therefore decreases the risk of miscarriage. And then progesterone deficiency, once they were pregnant, live birth rate was 100%. So that was really interesting. And we just looked at some of the male conditions. So morphology, 100% pregnancy rate, but only a 50% live birth rate, and very similar with motility. My feeling is that when we did this, we didn't know an awful lot about sperm DNA fragmentation, and now we do. And I think it would be different now I think the success rates would be quite different because we understand so much more about male fertility now. So that I would love to repeat that to see what happens because, I think there'd be quite a difference. We formed loads of collaborations. I haven't updated these recently, but these are some of the medical professionals that we collaborate with. So Professor Sheena Lewis, she is a professor at Queen's University in Belfast, developed the sperm comet test looking at sperm DNA fragmentation. Mr. Michael Dooley, we've done some work with him at Dumfries House, where Prince Charles has just opened an integrative health centre, and they ran a big women's health conference there, so we were involved in that. That was amazing. Dr. Cheryl Homer, she's an andrologist, and Mr. Brian Woodward, also an andrologist, so they do specialist male fertility testing. Dr. Marilyn Glenfield, she's an amazing nutritionist. We also work with the Fertility Show in London and Manchester. I usually go and speak at those events. I'm involved in their Q&A sessions. Fertility Fest, that's amazing. It's bringing art and science together. Absolutely brilliant. And some of the fertility clinics, Institute Marquez, European Fertility Network, Fertility Network UK is a charity that supports couples with fertility issues. And we just, Harris and I were, last Saturday, we were had a meeting with a clinic in Madrid to collaborate with them. We have an event we're involved in at a fertility clinic in London this coming Saturday as well. We're going to put a team of practitioners in the fertility clinic to to actually provide treatments throughout their cycles of IVF. So that will be fascinating. These are just some, very quickly, these are from some of our practitioners, rather than just me drawing my own, my own little analogies from clients I've worked with. I wanted to share some of the cases that other practitioners that we've trained have worked with. So you can see some really speedy response. So 4.5 years, they fell pregnant after 3 treatments. Trying for 6 years, 3 failed IVF, 14 treatments, they have a baby girl. A very more complicated, older, 37-year-old, perimenopausal, thyroid issue, endometriosis, 3 sessions, and she was pregnant. And just kind of flipping on quickly, this last one, this couple had been trying for several years. She was told she had a 1% chance of conceiving naturally due to her egg quality. So she had 8 treatments, and at the time of writing this, she was 34 weeks pregnant. So absolutely wonderful, really wonderful outcomes, the life-changing outcomes for the couples. So if you do want to have a go and have a look for further information, there's my website, which is serennaturalfertility.co.uk, or the association website, which is where all of our practitioners, when they're trained, can have their details placed on the website, reproductivereflexologists.org. So I'm just going to come out of here and hope that hasn't been too horribly boring, and I'm hoping that you might have some questions.
Oh my God, I have questions now.
Fire
away. Are you kidding me? I'm writing them down. How many can I ask?
You can.
All of them.
Some of them are goofy, but there's no bad questions, right, Sam? Shut up.
No bad.
Sam just muted himself so he wouldn't say anything rude. Okay, so my first question being that I have avoided, and unfortunately for Sam, he's heard me say this, I kind of fear pregnant women because there is an emotional aspect here. And when there's a miscarriage and when we're doing something unique to them, how do you deal with that situation? And have you dealt with that situation where, hey, you pushed a button and you made this happen, if it's unsuccessful, yet they get pregnant, you're still working with them. Yeah, it's just, I always look at that going, wow, I'm really intrigued by this. I want to do this. Yet there's that level of fear as not being a DR or doctor or being this voodoo that we do. Okay. So,
Okay, so the first thing to say is that we don't cover maternity at all on the course. This is all about preconceptual care and working with IVF. However, the protocols that we have, which is our kind of week 4 or week 5 IVF protocol, is designed to be safe in the first 12 weeks of pregnancy. So basically, you're not doing any direct work with the uterus at that stage. And you're not doing any work that could destabilize a pregnancy. So it is designed to be completely safe. And in actual fact, what we do have are techniques that we use to support progesterone deficiency by working with the ovary, which supports unstable pregnancy. So if you have a client who you can already see by gathering her data that she has had or has a progesterone issue, then you've got a means of actually supporting her pregnancy up to week 12, because it's usually it's that causes the problem. And so basically what we do with that in supporting a pregnancy is get her to continue temperature charting and to continue to self-stimulate her ovary reflex point up until week 12, which is when the placenta develops and takes over from progesterone. So if you have a client who is in the least bit worried, I always say don't do it. Don't, and you know, the you know, hands off. So, you know, it's just very much, if she is concerned, each client needs to be in the driving seat of their own path. And so you provide the information, and it is then their patient choice as to what they want to engage with or otherwise.
And you have so much science behind it that it's letting the science speak for it.
Yes, absolutely.
And that's what really is. And on that note, not to monopolize if someone else had something to say, but this is something I don't see. I mean, I see getting a lot of information from you in 4 days, like my head might explode. But what would be good pre-study and post-study to get to that level of confidence as a practitioner representing properly?
We do send you a reading list.
Oh, cool.
For both parts 1 and part 2. And I do have a book which covers far more than I can cover on the course. And
Yes.
And the book is designed so that, really not for you to read from cover to cover, but so that if you have a client that turns up and they go, oh, I'm having a natural IVF cycle, you can just go to the index and look that up. And there is all information about frozen embryo transfer, natural cycle, and you understand what it is, and you've got all of the pre-treatment protocols there to guide you through.
Very cool. Thank you. Yay, textbook.
Yeah, so the book is called, actually, bear with me, Kerry. Oh. You have a copy in front of me, so it's called Reflexology.
Yay. And you'll be bringing those in July, I assume.
I can bring some, yeah. I can bring some. I was just
online.
Yeah, you can buy it online.
Oh, okay.
I think the book depository is supposed to be very good. Or Amazon. Amazon sell it.
Amazon.
So
cool.
what I was going to say was, so I was talking to you about a treatment for short frozen embryo transfer. Whoops, it's my paper out my own, which you can see on there. So it tells you exactly what's going on, what you need to be aware of. All of the information you would need to know would be in the book. So the book has allowed me to cover an awful lot more than I can on the course. It's kind of allowed me to flesh that out.
Very cool.
Okay. So, any other
Carrie had a question.
Sam, you'll be that.
Carrie had a question about a client with a thin lining. You see that in the comments?
I can see that. Okay, yep. So the thing with that, Kerry, is that there are some really good techniques that you would use to improve the lining. And what you would want is, I'm guessing going for fairly regular scans to monitor that. And we would do probably a couple of things. But firstly, the first thing would be to stimulate the uterus reflex point to increase the volume and to increase blood flow, and possibly also some other, maybe work with the ovaries, but possibly also the endocrine system. It would depend on what was happening, what drug she was taking, and why. So difficult to be very definitive about it, but certainly, yeah, there is work that we can do. Yeah. Okay.
That's what I think really prompted me to invite you to come teach this at the Institute, because, as you know, we as a teaching facility and as a clinic are so assessment focused, and your answers are so contextual. And I think that that's where reflexology needs to be, because there are some reflexologists in some other books that are like, well, if you just press this button, everything will be okay. And that's not the case. There are so many other factors. We need to know about diet. We need to know about lifestyle. We need to, I love the charting. Like, we need numbers, data, testimonials. We need to data mine in order to figure out what could be contributing to the lining issue. And if that's the only issue, clients will write things on their health history form, and that might not even be our major concern as the professionals, because they might not know what they don't know.
Yeah, absolutely. Yeah, it's about finding out exactly what is going on for each individual. And the fascinating thing is that you can have 10 people all with the same condition, but they'll all present completely differently. So we need to tailor things to them. I mean, the temperature charting is fascinating. I mean, I teach it on the course, but I'm very aware that I don't manage to teach all of it. So I have a 5-hour webinar that we have on our website, which is just temperature charting. I've taught that I taught it as a lecture day over here, and we got so many requests for it, and I taught it so many times that I've managed to use this technology, thankfully, to teach it online. So now it's recorded, and people can just go into the shop and buy it. But it is 5 hours of looking at temperature charts, interpreting them, understanding them, looking at temperature charts for miscarriage and pregnancy and progesterone deficiency and luteal phase defect, etc., amenorrhea, anovulatory cycles, because they're all so so wide and varied. And actually, they are a fantastic tool for us, to understand what is happening. So that we can actually improve things. So Kerry, the website is our reproductivereflexologist.org, but those are only available to our practitioners once they're fully trained. Mainly because it won't make much sense, because I'll be talking about treatment protocols that you won't have learnt. So that becomes available once you've completed your training. We've got several on there. And the other thing that I do as well is these Q&A sessions I do once a fortnight for all students. I do them on a Wednesday, 7 till 8 GMT, and they're free to join. So when you're training, when you're doing your case studies, or even when you've completed your case studies, you can keep coming to join them and bring your more complicated cases or your charts you don't understand, and we just put them up on the screen and talk through them, so that you've got that ongoing support, because I'm very aware it's complex. It's, no case is the same, but there's lots of support out there.
It's a little overwhelming and really exciting.
Well, that's good. It's good that it's overwhelming, because it means that you're
you did it.
But we are aware that it can seem like that, and so we have now what we're doing this coming year is we're providing automatic student membership to the Association of Reproductive Reflexologists. That gives you access to our closed Facebook page, where there's 160 practitioners on there, all waiting to support and help each other. It's very active. And then you've got the webinars, etc., the Q&A sessions as well. So there's lots of support. Lots of support.
That is wonderful.
Good.
And speaking of support, brought me into another question. When you first started, because I actually listened to your podcast a while ago with Sam, and I'm trying to remember some of it. I know you started this quite a while ago. Mm-hmm. And in the US, obviously it's newer, I'm thinking. Yeah. How, in the beginning, I guess, how receptive were gynecologists, OB-GYNs, were the doctors to what you were doing?
Not at all.
Yeah. Yeah.
And there are still lots who aren't. But I always say, let's push at the open doors. And one of the things that we do, this is where the fertility show becomes really important, because we have a stand there. I do speak there. And it is in the main a clinical setting. So there are fertility clinics from all over the world that attend the fertility shows in London and Manchester. And my remit, alongside going and speaking, is to go and network. So we go and communicate with clinics and form collaborations with them. So, if we get someone who is interested, and what they're finding now. I've always said this would be patient driven. And what's happening is patients are going to clinics saying, I want to use reflexology as part of my cycle of treatment. Is that okay? What do you know? And they don't know anything. And so that's where we come in, because we will then go and, if the clinics are happy, we'll go and talk to them. And therefore, these things are always slow. They take forever, but gradually we are starting to see that that they are opening their doors and being a little bit more open, because in the main it's private medicine, and patients are saying, we want to use this. So therefore we're going, okay, well, we better do something about it. So yeah, if you have any fertility clinics who are who might be interested in me going to talk to them when I'm over, I am very happy to do that for you.
Oh, my dog just started, but I unmuted. Yes, and actually I might. I have a gynecology surgeon that said she'd connect me with someone if I learn things.
Yeah.
And so I'll get with Sam and talk to her, and maybe we can. Yeah. I don't know for sure. It's a real iffy, but I'll ask. That would be awesome.
Go and talk to them. I think the thing is that we talk to them on the same level. We talk the same language. When we go through the course, we talk in a very similar way to the medics. We use the same language, and if you use the same language, they understand what you're talking about, and they know that you know what you're talking about too.
Yes.
So it opens doors.
Absolutely.
I mean, sadly, reflexology is still seen as very fluffy, and we kind of move away from the fluff and move much more into the technical medical, and that means that you're able to provide a more integrative approach, and we get doors opening then. I'm not saying it's a magic wand, but it does help.
Yeah. Oh yeah.
Okay. Any more questions? Shall we come to a close? All okay? Yep.
I'm good.
Brilliant. Okay.
Yeah.
Well,
thank you so much, Barbara, for doing this.
Pleasure, an absolute pleasure. So what I'll do is I'll convert the recording and I'll upload it, and I'll ping you a copy, Sam, so that you can use it in any way that you wish, and I'll pop it up on the website too. And hopefully we'll see you in July.
Yes.
All right. Well, have a lovely rest of the day there. It's evening here. It's just gone evening, so enjoy the rest of your day, and hopefully I'll see you in July, and we'll keep in touch, Sam. Lovely. Thank you so much for having me. Bye now.
Ah!